All right. So I know that when we first started Project Echo, we did do a didactic on bipolar disorder. And I thought that we should do another one because we've had some new people come on. There's always more to talk about with bipolar disorder. And then also it seems to be something that keeps popping up with our folks. So I thought it would be worth our time to talk a little bit more about bipolar. So when we talk about bipolar disorder, first defining and diagnosing it. So bipolar disorders are distinguished from other depressive disorders by the presence of a manic or hypomanic episode. So I know I often, and this drives me nuts, I'll get a patient that has bipolar type 2 and major depressive disorder. And yeah, Dr. McMillan's shaking her head like, no, you can't do that. And so I think sometimes people don't think about the differences. And truly to have bipolar disorder, you have to have, a manic or a hypomanic episode. So the distinction is during a manic episode, the person is excessively elevated. They're really happy, sometimes grandiose. They believe they can do just about anything. If anyone has seen, I forget the movie, but it's got Richard Gere and I forget the woman in it. And it's a great portrayal of someone with bipolar and in a manic episode. But these people, very enthusiastic, energetic, and they tend to think that they can do, I don't want to say like superhuman things, but sometimes they really think they can do things that in their right mind they would not do. And a good example is in the movie that I'm thinking of that I can't remember the name of. He is at a concert and he's mad that he doesn't think the conductor is doing what a conductor should. And so he literally gets up and he walks on the stage and like shoves the conductor of like the symphony off the stage and starts conducting this orchestra. And of course it doesn't go well. But they believe that they can do things that they really can't. This can be dangerous. I've never had one that has been like this, but they believe, I had one person tell me about a friend who thought that she could fly. So she was trying to jump off a roof because she believed that she could fly. So I've never had a patient that has been like that, but I understand that's also sometimes what that can look like. The manic episode may also be characterized by some psychotic features, delusional beliefs, so the belief that you can fly would be a good example, and hallucinations. So the anatomical determinants of bipolar disorder, so individuals who have had the disease for longer periods of time, they have enlarged lateral ventricles. So one of the things that we know about bipolar disorder is that it's progressive. It will get worse if it's not treated. So the significant changes in the brain, I'm fascinated by the brain in terms of, we have the technology now through SPECT scans, through functional MRIs, even PET scans to really look at the brain and look at what's going on in the brain. And when we see how a mental disorder changes the makeup and the shape of the brain, I think that gives a lot of credibility to mental health and substance use disorders. When we talk about the difference between medical and mental health, and even right now in our legislature, in the Montana legislature, there is a bill that's going through about having mental health parity. And it's ridiculous that even though parity has been on the books federally for quite some time, that we still don't always follow parity. And I know at Rimrock we deal with that all the time. But looking at that, where if you medically, if someone has a broken bone and they don't get treatment, it heals poorly. It might re-break. It is sometimes disfigured, or they don't have range of motion and function in whatever was broken. And we never really could do that in terms of mental health, but now we can. Now we can look at the brain and see there are physical changes. So just like a broken bone that doesn't heal correctly, if you have a mental illness and it's not being treated effectively, it has the same, disformity, lack of a better term, in the brain. And then there's also a genetic component. This tends to run in families. And one of the things I ask my patients whenever they tell me that they have bipolar disorder is I say, okay, anybody in your family also have bipolar disorder? And if the answer is yes, then I say, okay, what medications are they taking? Because not that I can prescribe the medications, but I want to tell that patient, go tell your doctor that you want to be on that. Because a lot of the patients don't actually have a psychiatrist. It's their general doctor. And those, I'm not bashing general providers, but they don't have the knowledge that psychiatrists would about mental illness. If I hit the next one. So medications, and I will definitely defer to Michelle and to Dr. McMillan. So the medications for bipolar, lithium. Lithium is easily absorbed, results are fast. Long-term use can cause health issues. You have to really monitor the lithium levels. Kidney function can be really affected, and so that's something you have to monitor. Although there's been a lot of research too that looks at lithium as, you know, it occurs naturally, and it, who was it? One of the psychiatrists that I worked with one time said that he felt like everyone should have a little bit of lithium every day just to help even them out. Oh, well, okay, that's interesting, but I don't think we'll be seeing that in the vitamin store anytime soon, but Michelle's smiling at that. Gabapentin is another medication. So it mimics GABA, which is a neurotransmitter. It was originally an offline treatment, but now it is one that is an off-label, not offline. Close enough. I was close. And then Depakote is actually an anticonvulsant used to treat seizures, migraines, and acute mania, and it also is a nice mood stabilizer. We don't always understand why some of the medications work. One of the ways that I also unofficially don't diagnose bipolar is if a patient tells me they have bipolar disorder and they're only taking an antidepressant. If they're not jumping off my walls, they're not bipolar, because an antidepressant without a mood stabilizer would trigger a manic episode. So that's another way to kind of look at when you're trying to do a differential diagnosis. You know, if a patient is not taking any mood stabilizer, and these can all be considered mood stabilizers, and they're only taking antidepressants, then they're probably not actually bipolar. Go ahead and hit the next one, Sarah. So let's look at the actual definition. So bipolar type 1, this is the traditional bipolar that we hear about. This is where, you know, historically it was called manic depressive disorder. So you have to have at least one manic episode and one or more major depressive episode. So that's a pretty specific criteria. If they don't have a manic episode, they don't have a history of a major depressive episode, and those are defined, of course, in DSM, then they don't have bipolar type 1. Bipolar type 1 is equally common in men and women. The first episode in men is usually being mania, and the first episode with women is typically being major depression. I have had several people with bipolar type 1. So manic episode is a distinct period during which there is an abnormally and persistently elevated, expansive or irritable mood. The episode must last at least a week, and the mood must have at least 3 of the following symptoms, and I've listed them all there. So that's when you talk about, you know, especially that bottom one, increased pursuit of activities with a high risk of danger. They really don't sense, I guess is the good word, that there's a problem there because they have a delusional state. And then I don't know, Dr. McMillan, this would be a question. The episode must last a week. Let's say after 2 or 3 days, they end up in the psych center, and they get put on medication that ends the manic episode. Do you still count that as a manic episode, even though it doesn't meet the time frame?
I think it'd be variable. I think it'd be pretty unusual for if it was truly bipolar 1 and a severe manic episode, even in the hospital and even with medications, for it to totally resolve within the week. I mean, even if people come into the hospital, they're still looking manic, pretty manic as we first start medications for several days. So I think especially if it's severe sort of bipolar 1 full manic episode, it's going to probably last either way. But,
cool.
Yeah.
Thank you.
Yeah.
That's
my thought.
Yeah. So definition of bipolar type 2, I see a lot more people with bipolar type 2 than type 1. So bipolar type 2, they have a major depressive episode, and then instead of a full manic episode, they experience hypomania, high energy, impulsiveness, excitability, but less severe than a full-fledged manic episode. And of course, the difference between major depressive disorder and bipolar type 2 is that presence of the hypomanic episode. And I think people often miss that. The other problem that we see with substance use disorders as well is that a lot of times substance use disorders look like a hypomanic episode, and sometimes withdrawal might look like a depressive episode. So really trying to piece that apart, did they actually have a hypomanic episode, or were they on a meth runner? Did they actually have a depressive episode, or were they just coming down? And so looking at those, and I think that takes some time to piece apart. When I first meet with a patient, unless they have a previous diagnosis and they're on medication, I don't like to endorse any bipolar disorder diagnosis. I like to be able to, rule it out, and knowing that might take me a couple times of meeting them to really get a good feel for it. Go ahead and next one. A depressive disorder is defined by at least 4 of the following symptoms. They should be new or suddenly worse. They must last for at least 2 weeks. So changes in appetite or weight, sleep, or psychomotor activity, decreased energy, worthlessness, guilt, trouble thinking, concentrating, thoughts of death or suicidal plans or attempts. Major depressive disorder can also be hard when you deal with substance use issues because there might be situational depression. Certainly I've had patients come into treatment and they may have all of these symptoms, but then when you look at what's happened in their life, maybe they've lost their job, their family's left them, they have legal charges, all these things, it's like, well, of course they don't feel, of course they're feeling depressed. So piecing apart, is this actually a diagnosis or is this situational? And then how do you treat it? And what does the long-term treatment plan look like? So those are all things to poke apart as you work with the patient. Go ahead to the next one. So these are some medications, and certainly I would defer all of this, the rest of the didactic actually, to Michelle and Dr. McMillan, talking about, what medications you guys like to use, why you have preferred medications, et cetera, et cetera. So I'll turn it over to you guys.
Awesome. Thanks, Malcolm. I guess before I talk about the medications, I might just mention a little bit in terms of kind of differentiating, because I feel like it comes up a lot in our discussions, and it comes up a lot, every day for me, almost every patient I see, in terms of deciding if this person's really bipolar or if it's maybe something else. And it can be really tricky, even when I sit down with someone in person and talk to them for a long period of time. Sometimes it's really hard to tell. Definitely want to pin down kind of the depressive symptoms, and usually I start there and kind of making sure first, do they meet criteria for major depression? That's usually pretty easy. And people typically will report, a lot of those neurovegetative symptoms of depression and be pretty clearly able to tell you about times in their life where they felt depressed. The manic and hypomanic phases are a little harder, because I think a lot of times if people have had those types of phases, they don't accurately remember them or report them. I think insight can sometimes be impaired during those times, or they just felt really good and they didn't see it as a problem. A lot of times I think people enjoy being manic and hypomanic. That's sometimes one of the things we fight against in treatment, is that people like feeling up. They get a lot done, they feel really happy. And when you're normally depressed, that's great. That feels different. It's kind of exhilarating. You'll hear people talk about feeling sort of like they could do anything and kind of conquer the world, and who wouldn't want that? So I think sometimes people don't really identify that as a problem or pathologic. They just see it as, oh, I was doing great, or, having a good time at that time in my life. So I typically start kind of evaluating with the depression and making sure that that's truly there and that they've met criteria for major depression. And then I also ask people, is there a time, in your life where you've slept much less than usual and weren't yourself? And I don't want to feed them too much of the potential criteria for bipolar disorder, because I think sometimes you'll get patients who just agree to things or just kind of go along with it. And when left to their own devices, they may not really be able to clearly say, oh, yes, this has happened, and during this time I was like that. So I don't like to kind of feed people too much and have them disagree with it. I like them to kind of tell me what that time looked like and how long it lasted, what types of things were going on. And so if they're kind of clearly detailing a time where they were sleeping much less than usual, but didn't miss sleep, didn't need sleep, had a ton of energy, or getting more things done, or more impulsive, or doing risky things, or even just really irritable and kind of agitated, sort of, that's a big red flag. And then I would want to ask more questions about that. Sometimes people say, oh yeah, I didn't sleep for 2 days, but I was just really anxious, or I was studying for a test, or I was using drugs, or sometimes people with PTSD really don't sleep all that well, and so they only get a couple hours of sleep per night, but they're tired and they're sort of hypervigilant. And so kind of trying to tease apart, if they're not sleeping, why that is, what was going on then, and how was that different from usual. The other thing I run into, sometimes people will say, oh yeah, I'm impulsive and I'm distractible and all these things, but it's not a change from kind of their baseline. So this has to be kind of like a discrete period of time where all of a sudden they're acting differently. They're either much more energetic, much more distractible, much more impulsive. And so sometimes folks with ADHD, it gets really tricky too, because people with ADHD get really impulsive. They're really distractible. Sometimes they don't sleep all that well. They don't need that much sleep. And so it gets a bit tricky sometimes, but that is usually pretty chronic, and that goes on for lifelong. It's not just like a week here, a week there. And so really trying to pin that down. And so typically the bipolar 1 is pretty clear. People will have had a full-blown manic episode, done something impulsive, or people will have noticed, you're talking fast, you're more irritable, you're doing things that really call attention. And so that gets pretty easily, I feel like that's pretty clear. We could all probably recognize that. I think the bipolar 2 and the more sort of soft bipolar is where it's really tricky. And sometimes it can be missed, and then sometimes I think it can also be overdiagnosed. So, and there's some experts actually in bipolar who feel like it's really on a spectrum. So there's sort of this whole severity of bipolar disorders. And so sometimes there's people who don't really even fit bipolar 2, but maybe even a little softer than that. And they really do seem to have a little bit of mood lability, but not fully meeting criteria even for hypomania. So I think that's also a bit of an area of interest, and something that's still developing in terms of what do we do with this, and how do we treat this, and what do we call it, and things like that. So sometimes you'll see Instead of bipolar 1 or bipolar 2, you'll see like bipolar unspecified, where it doesn't really clearly meet criteria for any of the others, but it does seem to be somewhat of a bipolar spectrum illness. It's kind of what I would call that. And the reason I spend a lot of time kind of focusing on that in my interviews is because really we do treat depression much differently, major depression much differently than bipolar depression. And so these are a few of the mood stabilizers that we use, but there are certainly others. I think the atypical antipsychotics are kind of one of the big treatments. So things like Seroquel and Zyprexa, risperidone, those types of medications, and then the classical mood stabilizers like lithium and Depakote and those medications, and also lamotrigine is one that you might see a lot, or Lamictal, that's often used for bipolar depression particularly. So those are, some of the medications we use, and we do treat it pretty differently from major depression, because as Malcom mentioned, some of the antidepressants are, at least in theory, we think potentially going to trigger or incite a manic episode. I think the evidence on that is a bit unclear. Sometimes some of the studies show that antidepressants actually don't really incite that much mania, but there is concern about that. And so you don't want to necessarily, if you can help it, start an antidepressant without a mood stabilizer in someone who's bipolar. And some people would even argue people who are bipolar shouldn't be on any antidepressants. That's a bit more controversial. So I'll see if Michelle, it looks like Michelle might have a few other comments or thoughts. So I'm going to let her chime in if that's okay. It looks like she might have something else to say, and then we can kind of wrap up or ask any questions.
Basically, I think you said it really well. A lot of these meds, they're listed here. Some of them, we definitely don't see that often. The data doesn't support some of these, like using zonisamide or pregabalin or gabapentin alone monotherapy for mood stabilization. Sometimes you'll see it adjunct, but those aren't really that common. I think, selection of these things highly depends on the patient. It's very multifactorial. Things like how their liver and kidneys are functioning. Are they a young female that is, basically that has, what am I trying to say? Basically, if they're going to become pregnant or not, we're going to probably move towards the antipsychotics. If they have any other symptoms like anxiety or depression, sleep problems, we may choose one versus the other. And so I don't know if we really I don't have necessarily a specific one that I like more than the other. It just really depends on the patient and what's going on with them, how their body's functioning, and any other disease states or comorbidities that they have. So, yeah.
Thanks, Michelle. And then she also, as you guys can see, typed in an acronym for remembering symptoms of mania, which is really helpful. And there's a couple of them, but the one I always remember is dig fast. So I think that's distractibility. D, I is for impulsivity. I believe G is for grandiosity. What's F for?
Flight of ideas.
Flight of ideas, awesome. A, activation or agitation.
I think it's appetite.
Oh, okay. And then S is probably for decreased sleep, I'm guessing. And T, what's T for, Michelle?
Talkativeness.
Talkative, more talkative. Awesome. Thank you. It's been a while since I've used that one, but awesome. So that's one way to kind of remember it. But basically all those kind of criteria that we talked about. So grandiosity, decreased need for sleep, and energy. So I think sleep and energy